So, very good morning to all. Welcome to the IC on Simple Innovative Tips in the Operation Theatre for Optimal Outcomes, a video-based course. I know it's a post-banquet day, and on Saturday morning, 8 o'clock course can be a little bit challenging, but I would like to thank everybody who's present here. The idea of this course is like what challenges do you face in the OR or before the OR when you're planning your cases, or a little bit of post-op challenges. We are going to cover those topics today from a refractive surgeon point of view, and not just refractive surgeon point of view, it can sometimes help you in your other surgeries as well. So without further delay, on my behalf, I would like to request Dr. Saili to talk about back to the surface, perfecting the art of PRK. We all know that PRK has its own set of challenges, and she's done extensive work in tackling those. So I would request her to give her talk. Thank you.
Good morning, everyone. Thank you, Dr. Pooja ma'am, for giving me the opportunity to talk on your behalf. So I'm going to be discussing an innovative method that we've introduced at Narayan Nethralaya for controlling postoperative pain in photorefractive keratectomy. So to begin with, PRK was the first excimer laser procedure approved by the FDA, and having the advantage of being less destabilizing to the cornea and being suitable in a wide variety of thin, steep, and flat corneas. We are still facing the problem of postoperative pain, which has dampened the enthusiasm of both surgeons and patients in performing this procedure. And this is largely because of exposure of nerve endings, enhanced spontaneous activity of the injured nerve fibers, and release of prostaglandins and neuropeptides. So, significant postoperative discomfort, which is not amenable to routine pharmacological analgesia, is a problem statement that we're still facing in most of our patients. And the current management modalities include topical analgesics, which are known to cause surface toxicity, subepithelial infiltrates, and keratitis, and oral analgesics, which are limited because of their limited maximum daily dosage. So, the need for effective non pharmacological means of pain management is still felt. We have previously approached this in a different manner where we used bandage contact lenses soaked in ketorolac 0.45%, which acted as a drug depot, which continued to release the drug in therapeutic concentrations after PRK. And we noticed that with this approach, the pain scores of the patients did come down, but we wondered if we could bring the pain even further down. So that led us into this journey of understanding cold as a therapeutic agent throughout history in medicine, and it has been used not just in ophthalmology but also in other fields such as cancer medicine, sports medicine, etc., and with heartening results. So we wondered if we could bring this form of thermotherapy in the form of refrigerated bandage contact lenses to ophthalmology to help reduce post PRK pain. So, we performed a study where we included patients with early to moderate keratoconus and normal eyes undergoing refractive correction, and they underwent a thorough diagnostic evaluation before undergoing either manual cross linking or PRK. So each eye being treated was randomized to one of two groups: the conventional group, which received the BCL at room temperature, and the cold group, which received the BCL, which was stored at 4 degrees Celsius overnight in the refrigerator. And this cold temperature was maintained by removing the BCL immediately prior to placement on the patient's eye. All of these patients, after undergoing either PRK or cross-linking, received a cold BSS wash for standardization, and BCL was assigned at random. Pain was recorded on the first, second, and third postoperative day. So in our PRK group, we noticed reduced pain scores in the subjects who received cold BCL as compared to the room temperature BCL. 80.4% subjects reported the reduction in pain score, and 19.6% patients reported either no difference or increased pain following CL-BCL use. Similar results were obtained in our cross-linking group, and we noted no significant difference in the epithelial healing time, and none of the patients developed any signs of infection. So we knew this was working at the clinical level, but we wondered if we could explore this at the molecular level as well. And we studied these receptors, the TRIP channels, or the regulatory channels, transient receptor potential ion channels, which included the TRIP M8, TRIP V1, and TRIP A1, and the inflammatory genes, which included the calcitonin gene related peptide and the interleukin 6, which is a pro inflammatory cytokine. We wondered if we could study these receptors on the undersurface of the bandage contact lenses to prove our hypothesis. So we collected the BCL from patients who were undergoing contralateral PRK with cold BCL in one eye and conventional in the other. These were transported in phosphate buffered saline and underwent a series of experiments to understand the normalized gene expression. So what we noted was the TRPM8 channel there was increased absolute and relative expression of the TRPM8 channel in the patients who were reporting reduced pain with the cold BCL, giving us an idea into the molecular reason why they were experiencing this reduced pain. So we noted both reduced pain scores at the clinical level and the corresponding answers at the molecular level in these patients. And there were a wide variety of mechanisms which could possibly be acting. There could be, as per the gate control theory, there could be reduced stimulation of the A beta afferent nerve fibers, reduced nerve conduction velocity, and reduced sensitivity to pain receptors, along with reduced metabolic rate and cellular activity, causing a reduction in the inflammatory factors. How did we sustain the pain alleviation over a 3-day period is a question that we get asked commonly. So this is not acting over a 3-day period, but the immediate dampening of the inflammatory mediators along with upregulation of the cold sensitive receptors is making the action of the routine analgesics which you administer orally or otherwise causing a superior response to medication at a later date. So we already knew that we do face significant postoperative pain after PRK, and conventional pharmacotherapy does yield suboptimal results. We've added a novel and simple technique to control post-PRK pain with no added risk of infection, along with identification of molecular targets for treating post-PRK pain. Of course, pain is subjective and may be over or underreported based on personality types, so that remains a limitation of the study. Thank you.
Thank you, Dr. Saili. So just to give a like we do know that the cold BCL does work in post-PRK and post-cross-linking patients in reducing the pain significantly well. Just one tip if you would like to give to the audience of how they can enhance the effect of this cold BCL.
So one thing that we do practice is we keep the bandage contact lens overnight in the refrigerator. This is not something that you would just keep half an hour before the procedure. You would want to keep it overnight and remove it just prior to placing on the patient's eye, because even the minute or two that it spends outside can reduce the temperature to room temperature again. So immediately post ablation, just prior to placing the BCL, you would need to remove it.
Thank you. So that's a very important point. So I would now like to invite Dr. Rohit Shetty sir, who would be giving his talk on customized lasers for normal and complex corneas. Yes, sir. Mm-hmm. Just one. Siley, can you?
So what I will ask her to comment on this, but what happens is the entire cold pathway modulation works on those TRPV channels. These are the ones which are there on the surface of your eye, like your corneal nerves and the epithelium and those things, especially the nerves. So when you use it on your lids, you are using an indirect change on this. It may still dampen it, but it may not be as much as at a direct one. When you put a contact lens, you're directly dampening on the ocular surface and the nerves. So you're completely taking care of this. So that is how the difference is. Anything else on that? And what we did was we used recently imaging using the cold thermography. This one, you have this special devices which looks at the heat map. Rushad has been working something similar we work. It's quite interesting when you put it and how the temperature changes. And we have seen that the temperature in the first 3-4 hours is maintained well with the contact lenses. That's the time when all this channel starts functioning. So once you knock it off, then it doesn't go to the same level as before. So your pain does not even though the temperature, once you put contact lenses, we have seen that it maintains the temperature close to 2.5 hours. Yes, the temperature is gone, but what happens is in when you put this is all your receptors, which actually triggers the pain. You put it in, the receptor is dampened. Even if you take the lens out, it is already dampened here. So that is where it is important. It's not that cold is going to be forever. We know the temperature is, say, once you hit the ocular surface temperature, it changes. For them, we put the drops. We can use one of the ketorolac drops on them. You can change the lens again. We do it. Sometimes when they come back, the next day morning, we change the to cold. Whatever we change, the cold contact lens is always cold. So irrespective of when you change the same day, what harm are you causing? Nothing. In fact, many of our patients who are not, forget about the bandage contact lens, those who are not tolerant to lenses, you tell them to keep the lens in fridge and use it every day, the daily disposable, the tolerance is very high. So, people who come back to you saying that we can't use those lenses. In fact, it's 100% they become tolerant. Cyclosporin drops, which you normally patients are not responsive. They don't like using it. Stings, irritates. You keep it in the fridge and use it. Cold dampens everything. Thank you. My talk today is on customized lasers for complex corneas. These are my financial interests. When you look at customization, there are two important aspects of it. One is, uh, when you look at those 10 commandments, one is having a robust diagnosis, another one is using a thinking machines. Most of the customization needs to be taken care from the how your cornea is shaped, the way it's made up of, this astigmatism, the whole mix of aberrations. What is important is the customization should start from the epithelium itself. And epithelium itself has the Zernike parameters. It has a normal epithelium will have absolutely no cylinder in it and perfectly normal corneas. But when you have an irregular epithelium, the whole customization becomes more challenging because the lasers are not meant to work on an irregular surface of epithelium because there are multiple curves on your epithelium, and that's one of the major challenges we feel when you have a quality of when you look at the quality of vision post surgeries. So understanding cylinder is very important because cylinder is just not a component of geometrical X K1 K2. It's a mix of multiple axes which is hidden because most of those axes are driven by your aberrations and multiple other factors which you cannot correct with the glasses, probably rigid contact lenses, but not with the glasses. The topo-guided treatment is all about making those imperfection right. The wavefront optimized is all about just one. It just follows a Muller-Lin formula and just looks at one ablation pattern compared to what you do on a topo-guided treatment. The different type of customization is topo-guided, which is anterior surface of the cornea, and but your posterior surface is not taken care of. And in a wavefront guided, it's a complete system is what is looked at. There's a very old slide from when customization was introduced in for the wave light. They spoke about the topo-guided treatment in irregular corneas. When your aberrations are very high, you can look at total aberrations are too high. You look at the wavefront guided, and when there is everything is perfectly normal, you don't touch the cornea and unnecessarily do anything, and then you look at wavefront optimized, which is a non-wavefront guided technique. So today the concept of contura came in because you are worried about this significant 40% of your patients form in this category where your cornea is filled with many aberrations patterns. So when you treat those aberrations pattern, you need a customization, and that is the first level of customization what we see in a healthy normal corneas. Schwinn PRK is one of the most highly driven customization we can think of because it takes in data from your topographies, from your epithelium, and it's fed into the system. There are two types of customization here. One is a corneal wavefront, which uses a cirrus. Other one is a total wavefront, which is an ocular wavefront. And these are what we call it as aberration-free, the custom corneal wavefront, the Presby Max, which is your corneal, which is your laser vision correction for presbyopia. The pattern of ablation is all driven by the epithelium. One of the biggest customization is ability to treat the periphery and the center, and the subjective correction is entered here. And you can compare between which one is better and what is the ablation profile, whether the cornea is better or the total I want to do. And you can see the maps here, and you can check what ablations, how much depth of ablations you're doing. So you need, it's a true form of customization to choose between the both. And then you can go to manager, play with these things, which no other machines in this world can do it. You can choose the aberration you want, you can delete what you don't want to correct, and the machine itself will help you to correct or delete these aberrations. And by doing it, what you're trying to do is you're trying to give a person a more uh, tissue saving, which you probably would not see in your regular ones. A lot of this customization helps in remodeling. And the major area where the customization work is in the topo-guided treatment, when you're looking at both the custom wavefront or the ocular wavefront. And here, the big thing is that you can place these two images side by side. And when you do a side by side, sometimes your corneal wavefront actually is burning more than the ocular wavefront, because what happens is your lens is compensating around 80% of your corneal issues. So if you have, when you look at customization, and if you have only one machine, then you virtually are driven to treat everything on this platform. But when you actually have the total corneal wavefront measure also, you see that your aberration is just around 9 microns compared to what you see here. And this is something which is a huge impact, is because the ocular wavefront negates a lot of corneal issues, and it makes your ablation much different. For example, if it's a cornea wavefront treatment, there's so many aberrations trying to treat. Why is trying to treat is because it assumes that everything which is happening in your eye is from the cornea. But minute you do ocular wavefront, half of what was treating it actually deletes it. Why does it delete it? Because it says that the lens is compensating. You don't need to worry about all this ablation. When you delete this, your ablation actually drops down. You are reducing it by around 17 or 20 microns. 20 microns get just completely deleted there. That's the big difference between the ocular wavefront and the total wavefront. And one of the advantage here is what the cornea was treated as 4 diopters, 4 microns, that is 5 diopters of coma was treated if you assume that cornea is the only optical system in your eye. But when you do the ocular wavefront, it only treats 1 diopter of coma, because the other 4 diopters of coma, the lens is accommodating and it is negating the coma itself. So it's a huge advantage in customization is, if you do Alcon or any other machine, it would treat 5 diopters assuming that everything is coming from the cornea. It will miss the lens completely. So unnecessarily you will be burning 5 diopters of coma will be treated, and you will be burning a lot of tissue, what you see here as 24 microns. And here you're burning only 1 diopter because 4 diopters is using the accommodation. Accommodation is already taken care of it. And that's one of the reasons the true customization is when you use the whole ocular wavefront. And this is a classic video here which explains this, that how the lens, this is a accommodation of a lens, and we can just see how the lens is accommodating here. And it is accommodating exactly similar to what you see on a topography. Exact same thing. This is from an Osiris. As the patient is accommodating, you can see that now it matches your topography. It's matching the topography because that is what is giving you this 5 diopters of cornea is matching. So it is 4 diopters of this just goes off with just accommodation. So that is one of the big reasons why why this is very important in understanding a customization of lasers. And these are a few examples how we treat, and few examples of the pre and post ops. And there are times when corneal wavefront is better because the lens is over accommodating, so you end up in having more challenges. But here you can see that you can choose. The true customization is choosing what you want to choose for your patients. And sometimes when everything is bad, then that's a challenge of what we call it as trek. This is something which we can do it on Schwinn platform, and you can create a small PTK at the zone where the cone is, and the rest of the area you can manually remove it, and you can do a cross linking. And the PTK is just around 10 microns more than the epithelial thickness here, and that's something which we have given out here. And of irregular corneas, like these are the patients who would come to you for cataract, but they have an RK, very bad corneas, and you can regularize them. And post regularization, now you can think about any premium lenses also if you want to, because your cornea has become more regular, even with the very, very bad stigmatism, a very, very bad scarring. There are a lot of scarred corneas, and one of the major interests for me in treatment of a customized laser is scarring. I get a lot of the scarred ones. This is a patient referred to me who had maybe a buttonhole or a loss of flap, and the doctor said he was not sure. So it looked like there was a scar in the center, and she was very unhappy with this thing. And this is one more patient who looked like had a similar kind of a pattern, and this is how it looked. And this is how you can do you can't do a PTK because there's some areas between the scar which looked healthy. So you can build some custom laser approach, and using the CW platform, make the zone smaller, take out aberration what you don't want, and then you just see the pattern. The pattern of laser is exactly what, sorry, wherever there's a bump which is flat, it's trying to make it steeper. Wherever it's steeper, it's trying to make it flatter. It's a very beautiful way of even treating scarring. That means this area, it made it to bump more, and this area, the bump, it reduced. And this is what we looked like. And you can see that the scar completely disappeared. And if you look at the OCT here, this area had already, which was very greater, has bumped in, and these two areas had gone in, and this is the aberrations at this point of time. And I've discussed about the trek, and I can just, and I think this is also a similar case where we use the same trek for this procedure. I think there's some. And this is exactly one more case where we created the same scarring in that areas was corrected. Thank you. I'll just stop here for the interest of time.
Thank you, sir. So if you would like to give one tip at the end of the talk, what would it be for everybody in like?
The one tip is play with your machine as much as possible. What the companies tell you, they only tell you 1% of what your machines can do. And whenever you travel, visit, meet people, figure out, everybody would have picked up one. Sir would have picked up one. Saura would have picked up one. I think if you really pick up one, it'll be having more uses than what the companies would say. And none of these were part of what the companies say. So they were very rigid of what you can do, what you can't do. Thank you.
Thank you, sir. So now I would like to invite Dr. Sonu Goel, sir, to give his talk on bringing back that smile, achieving the elusive 6-6 on day 1 in smile surgeries.
A very good morning, and thank you for making me a part of this course. And I think the talk from Rohit is very elusive. I think, yes, we actually need to explore the machine, and there are certain, areas where actually you can go and, explore So the topic given to me is bringing back that smile, achieving 6-6 on day one in smile surgeries. So I think the goal of all of us as refractive surgeons has been 2020 day one. So a quick look, thanks to Dr. Rupal Shah for sharing this journey. So the journey of smile started in 2006, and it was when Secondo and Blum, commenced the first lenticle extraction, and the world never knew that this could be one of the laser platforms that would establish, and major lenticle extraction would translate into one of the major kind of refractive surgery. So we all know that the key steps in smile surgery basically include the lenticule base, and this is the base which takes around 10 seconds, the side cut 2 seconds, the cap cut around 12 seconds, and the cap side cut around 2 to 3 seconds. So these are the four key steps when you're addressing a lenticule on this platform. A quick look on what happened initially. So when the trials started and the machine came up, it was the scan pattern A. So what I really mean with the scan pattern A is when you're cutting a lenticule, you're doing a spiral out. So what does this translate into? So when this was the lenticle cut and it started the spiral from the center, and as it was moving, these gas bubbles were causing disruption of the cap cut here. So what I actually translated was this kind of dissection of the cap. Now this is what actually was inhibiting day 166 in the earlier platforms. And this was the transition when Dr. Rupal and her group gave to the world what is called the scan pattern B, and they started what is called as the spiral in, what we see now for the lenticle dissection, and the spiral out for the cap cut. And that is what actually transformed into 2020 day one. So this was a breakthrough in the lenticle dissection in on the Visumax platform. And we all know that achieving a good vision quality on day one is basically linked to a lot of qualities of the laser system that we use. So high pulse repetition rate. So initially on the Visumax 500 platform, we had it was a 500 hertz machine, but now with the 800, it is 2000 hertz. So high pulse repetition, reducing the time. It gives you you have to have a very low and a very stable laser energy so that the lenticle dissection is quick and easy, and the ultimately transforming to good quality vision on day one. And the laser has to be accurate in focusing, and there has to be a very small spot. So the spot sizing now translates from 4.5 for to almost 3, the spacing, and 1.5 for the side cuts, and that is what translates into a very smooth dissection, ultimately leading to what is 2020 day one. So this 800 is a 2000 hertz, which basically boils down to the total duration from 28 seconds to almost 10 seconds for the lenticule, and 5 seconds for the flap. So basically the shorter section time increases the peace of mind both for the surgeon as well as the patients. And yes, a lot of research, which I'm sure Rohit will take forward into dry eye, and what is the effect of the suction duration reduction vis-a-vis induction of dryness post-operatively in these patients. So suction loss has been the biggest bug, and we all know through various multi-center studies that it is almost close to 1.34%, and 52% of the suction loss usually will occur during the first half. That means the 13 seconds of the surgery in this Visumax 500 platform. So boiling down to the duration, when the reduction of the whole treatment goes down to almost 8 seconds. So gone are those days when you actually found the suction loss. A very good paper in Cornea by Dr. Tatyal and his group came out that the learning curve of smile is basically the dissection, and it is the dissection and extraction which is the most challenging step for these smile surgeries. And you have when the spot spacing reducing from 4.5 to 3, and the side cut to almost 1.5, gone are those days when actually you would find patients with stromal damage or anterior cap tears or side cut tears and retained lenticules. So the dissection becomes very smooth, and these complications which we normally now find in literature and hardly we experience with the best of the hands basically ultimately translate into the patients having 20/20 vision day one. One great feature with the 800 platform is the central line. We all know that if the decentration is more than zero point 0.3, there is induction of aberrations, specifically the coma and the spherical. And that is more translated when you have a high level of astigmatism, maybe more than 2.5. So the center line system, if you watch here, basically you need to align this visual axis onto the center of the circle, and this takes care of the angle kappa. Shortly we'll have the equipment talking on the forum where the atlas would be linked and the XY on the atlas would directly be on the Visumax 800. So the alignment would exactly be what is required as per the topography picture on the Atlas equipment. So a quick look of what we do in our OR and how does this equipment behave and how do you translate good quality vision is a good clearing of the meibomian, drying, and this is how so there are two arms to the equipment, and this is the operating microscope. This would swirl, and then the laser microscope comes in, and this is the disposable suction device. So this is the joystick, and this is rotated, so that the laser delivery system cone comes down, and this is the suction device which is hooked and the other end onto this laser delivery and gets self-illuminated. And then you have this graphic interface display where you are, and this is what the centration I'm talking about. So if you have, you ask the patient to look in the light, the center, the circle is threaded and just ensure that it remains within this. So the decentration would be less than 0.2. So 80% once it is achieved, docking, you apply suction, and this is what the spiral in, and this is the spiral out that I was talking, the side cut, and it is just 8 seconds that the whole procedure is completed. So actually, this translates into almost no suction loss. So almost 400 eyes over a period of 5 months that we did, not even a single patient of suction loss. So this is, just watch the smoothness with which we are able to dissect. So I go down, I go under the cap, and this is very slowly, very gently, and without any effort, very smooth dissection under the cap. I go underneath the lenticule, I go left, leave a stump there, go slightly on the right side, dissect it 360, and then release the stump that I've created. And Gaurav has taught us this wonderful hydro expression of the lenticule. And this is what, actually translates day one. This is the slit lamp picture. You hardly can make out any sign of surgical trauma, and basically translating to a good quality vision day one. Another very important feature with this equipment is the ocular system for the cyclotorsion alignment. And on the fly, this machine can be hooked to the ILMaster 700, where the pattern of the vessels can be recognized and the astigmatism can be actually be controlled. But since this is yet to be released, so initially what we do is we mark alignments here, and the moment we take the patient on the fly, you can actually, after applying the suction, you just see, watch, you can rotate and you can align the pattern according to the desired axis. So the treatment is bang on target, and whatever in the literature talks of the cyclotorsion close to 3.3 or 4 degrees, I think this can be taken care, and specifically in patients with high astigmatism. So all of this ultimately boiled down to our initial results, where the spherical and the cylindrical equivalents have been almost close to zero. And one very interesting study that we observed is the reduction in the mean HOA. So there was a significant reduction in the post-operative HOA in our initial cases, series of cases that we saw. And this all boils down to a better refractive outcome under this platform. Predictable, it's quite safe, patient is very comfortable day one, and the ease of workflow is amazing. and basically boiling down to less surgical and OPD man hours and peaceful nights, and ultimately patient achieving a good 2020 day one. Thank you. Thank you once again.
Thank you, sir. While Dr. Saurabh sir is setting his presentation up, I would have two questions. So there are a lot of times that we come across dense OBL after the laser has fired, and when we try to dissect, patients are extremely not cooperative because they can't see the white light to concentrate on. What would you do in those situations?
So it's quite tricky what you're talking. So it actually depends upon your own personal experience, and you really need to take the patient into confidence, and you really have to be very, very careful that you don't accidentally cause those cap tears in those circumstances. So I think patience is the first thing that I would, like to add to this. The second would be the right instrument, because using anything sharp would, actually cause chances. The biggest 12 that I feel is the best for these conditions.
Thank you, sir. And you remove the lenticule while doing the like you dissect it and then you hydro explant the lenticule. Do you think using hydration in the interface would lead to?
Yeah, so that's a very nice question, and there has been quite a debate on this now. So the dissection is so smooth that now actually you don't need to, even hydro express it. You can just hold it and just pull it out. So I think yes, that could be one thing that now we are slowly, from hydro to just simply pulling it off.
Thank you. Thank
Thank
you,
you.
sir. So now I would like to invite Dr. Saurabh, sir, and he would be talking to us in choosing the right fit in phakic IOLs.
Good morning, everyone. Thank you, Dr. Pooja, for inviting me in this IC. And I'll be speaking about the phakic And so this was the first IPCL, phakic which I did 10 years back, and the patient followed just few days back, and you can see how clear it is and well centered. So I think phakic has transformed our refractive procedure for sure. So I will not go through the routine of phakic because we already know. So I will just highlight the points where we can do something differently. So I think one of the things which I have noted in my practice is that most of these phakic patients have very high myopic errors. And when the myopic error goes above say minus 15, 16, and particularly if patient have subnormal vision, say 618 or 624, the accurate refraction sometimes becomes a problem. So what I do in my practice, if the patient's vision is subnormal and with regular spectacles vision is not improving, then we do contact lens back calculation. So why this is important is because many times patient will have maybe similar vision. Say for example, patient is high myope. So between minus 18 to minus 20, patient may have similar vision because it's subnormal. And if we correct minus 18, sometime patient may land up with residual minus 2. And if we correct minus 20, patient may land up with residual plus power. So to avoid that, what we do is that we use contact lens, trial contact lens. If patient is wearing already, that's better. And then we do, based on vertex distance, we do back calculation. So we get exact refractive error that the patient has. This is apart from the cycloplegic refraction that this is just for the beginners. Whenever we say ACD for in case of phakic it's always AD, that is the aqueous depth. So we have to subtract the corneal thickness from the ACD, which we have to remember when we are beginning these phakic. Now you can use various devices. Most of them are almost similar. Stick to one device whenever you are calculating. So generally you get a better idea. Now white to white I think is the only measurement that it has to be very accurate to have good, because volt is the final thing which determines the final success of our phakic. So we always prefer electronic calipers under the microscope, patient lying supine. And this is what something I want to talk in a short video. Apart from using digital calipers, what I do is that after doing the digital calipers, I just put it on a scale and check whether that correlates, because sometimes these digital calipers, the calibration may go wrong, because when we get it, the calibration is right, but over a period there might be some mechanical issues and we may have missed calibration. So this is best way to calibrate it ourselves. So this is a short video showing how to exactly take white to white diameter. And what is most important is to understand the surgical limbus, because we have variations in the surgical limbus of a patient. Sometimes patient have very wide surgical limbus, sometimes it's very narrow. So when we say white to white with respect to phakic what we have to do is take it from the mid limbus and don't take it exactly white to white. So you can see here I am measuring it under the microscope. It's too short. You can see that it's not. And now I have increased the size, and you will find it is actually white to white. That means it's slightly bigger than the darker area. Just go ahead a bit. Yeah, okay. So this is actually white to white. You can see it's incorporating right from back, but it is bit large for the phakical. So in cases where there is a wider surgical limbus, what we have to do is take it from the mid limbus to mid limbus. Otherwise, we usually end up with the oversizing. Generally, once you take one eye is white to white, generally the rule is that other eye also has same white to white. So keep the same calipers as it is and measure it for the other eye. And as I showed earlier, so this is measuring of the fellow eye. Most of the times you don't have to change anything. Usually the white to white is similar. And after that, as I showed, just measure it on the scale to avoid any problems with the calibration of the calipers. UBM has been talked about a lot, but I think it has not improved accuracy any further. So I think we have to stick to digital calipers. Other devices also you can use. The advantage of using other devices is that you can have a correlation between white to white. So sometimes you don't have to see the white to white diameters measured by other equipment. Just do the digital caliper measurement, and generally in your equipment you will find there is a correlation. For example, what I find when I do the white to white with ILMaster 700 and then with digital calipers, the digital calipers always give 0.5 less white to white as compared to 700. And in case of Cirrus, the HVID is almost similar. So if there is a mismatch between these readings, you can go back and again check the white to white. Now, in case of slit lamp examination, and distant direct ophthalmoscopy is very important because you should not miss early signs of cataract, because some of these patients may have cataracts, and if you miss it preoperatively, postoperatively it may be a problem. So don't take this make sure that you examine thoroughly. In some high myopes there might be mild subluxation, so it makes sure that you examine these patients properly after full dilatation yourself, so as not to miss this kind of patients. Other tests preoperatively are very important. Now, before ordering the phakic, most important is reconfirm all the data, including the refraction, axis of cylinder, ACD, and white to white yourself before ordering, and recheck the phakic which is selected by the company. Double check. So this avoids many problems after the in the post-operative period. Now, during surgery, my tips are that do not do over-aggressive viscoelastic wash. I prefer a passive visco wash. The idea of passive visco wash, where I just flush out the viscoelastic from the anterior chamber, is that there should be very minimal fluctuation in the anterior chamber depth during phakic implantation, because we are dealing with very high myopes. The lesser the fluctuations of the anterior chamber during the surgery, lesser will be the post-operative retinal complication, because the post-operative retinal complication is because of acute PVD induced by the procedure. And basically, when you are implanting a phakic, it's like a trauma to the eye. Lesser the fluctuations in the anterior chamber during this period, lesser will be the chances of acute PVD and lesser will be the retinal problems. The preferred viscoelastic is 2% HPMC. Of course, few do hydroimplantation as well, but the idea is to have least amount of anterior chamber fluctuation during the procedure. In the early part, I think it was advised, or maybe other phakic surgeons were using pilocarpine to do surgical PI, but it has to be absolutely avoided. This was my first case I did in 2013, and as usual, I did the surgical PI and put pilocarpine. I saw this patient 2 hours post-op and did a OCT. There was absolutely no wart, and it was very frightening to see that. So I just stopped. I saw the patient again next day. The wart was there. So it was the effect of the pilocarpine, which was pushing this phakic down to the anterior lens surface, and which I found out. So after the first case, I never used pilocarpine. What this pilocarpine does usually, though, is that it leaves these kind of deposits on the anterior lens surface. Most often, it disappears after a month or 2 months, 3 years. This is the same patient which had anterior deposits, but after 3 years, you can see it's clear. So it's reverses, but I think best to avoid pilocarpine. Same is true during intraoperative, maneuvers. Don't push the central part of the IPCL back on the anterior lens surface. That may leave these kind of changes for some period post-operatively. Now, few of the noted common complications which you can avoid by adjusting the post-operative regimen, we found because these are high myopes, there are higher chances of being steroid responders. So there is no need to give post-operative steroids for more than 7 days in these patients because there is hardly inflammation post-operatively. So after 7 days, just stop the topical steroids. You can continue with NSAIDs for some more time. Another thing, because many times companies say that if you have say small cylinder, say minus 0.5 or minus 0.75, you can neglect it and go for a spherical IPCL because it will reduce the cost for the patient as well. But if you're dealing with smaller refractive errors, for example, if you have a patient, say very low CCT, and you have power of say minus 0.5 with minus 0.5 cylinder at 180, remember that your surgical induced astigmatism will be much higher because patient already has low CCT. So it will not be usual 0.2, 0.3. I have seen that with lower CCT, SIA can be as high as 1 diopter. So what happens that if you use a spherical IPCL in this case, patient will end up with residual cylinder. So as far as possible, go for a toric phakic. Now, one of the common things which is noted after phakic, particularly in very high myopes, is that patient may have accommodation paralysis. So generally, patient will come back after a week and say that I cannot read clearly, though the distance vision is clear. What I have seen is that it recovers usually in 2 to 3 weeks. There is no need to worry. Just wait for some time and it will recover. So that has to be told to the patient. Checking the ward, we can, if you don't have, nowadays everyone has OCT, so that is the best way to do. But if you don't have, you can use the slit. Now regarding sizing, because this is the most important part, the perfect size has been told to be between 300 to 700 micron. But generally what I do, I target 500 to 1000 microns. The reason is that with higher wall, there is lesser chances of IL rotation. That's what I have seen. Lesser chances of cataract. And remember that every year the wall reduces by around 10 to 20 micron. It may vary patient to patient. So if you see after 10 years, the wall is going to be reduced by 150 to 200 micron. So suppose you have wart in a phakic patient of 400 or less, patient invariably is going to have lower wart over a period of time. These are the patient who land up with higher chances of cataract formation. So my choice is to go for little higher wart. Now for sizing, as you know that the same eye, if you use a larger size of phakic it's going to go for a higher wart, and lower size goes for a lower wart. So if you see the calculator used for phakic there are a couple of things this affects. One most important thing is white to white, so you have to be very accurate with that. Second thing, also the ACD changes the size of the IPCL that is required. Here, if you can see clearly, both these measurements, the rest of the things are same, except that ACD is low in one patient, 3, and ACD is 4 in another. And the change in the size of the suggested IPCL is of by 0.5 millimeter. So remember that also changes the size of the phakic that we are going to use. Apart from that, even the keratometry changes the size. So the same patient, similar other things, but keratometry you can see has jumped from 43 to 47, and size has jumped from by 0.5 millimeter. So if you are not very careful about entering all this data, you may land up with errors. Now same thing, what happens is in keratoconus, where there is erroneously very high AC keratometry, which the software interprets as high ACD, but actually it is only the central ACD which is high, but peripherally it may be a normal ACD, and you may land up with oversizing of the phakic in keratoconus. So in these patients, you have to be specific, customized, and you may have to go for a slightly lower size IOL, IPCL, phakic IOL. Apart from that, always check whether patient is going to use the scleral contact lenses after using the phakic IOL. If you are just debulking the spherical part of the refractive error, it is better to use just a spherical phakic IOL rather than a toric, because if patient uses a scleral contact lens after a toric phakic IOL, patient will have to use a cylindrical correction over the scleral contact lens. So that has to be determined before you plan for the surgery. Now I'll just skip through. I prefer one eye at a time because I want to see the world. I will just give an example of these twin sisters which I had operated. Both had same refraction, same refractive error. All things were same except white to white was 11.2 in one patient and another 11.4. So in the first twin sister, I used a phakical which was selected by 1.3 millimeter difference. I got a 1300 micron volt. Waited for 3 days, it reduced to 900, so which was good. And then for fellow eye, I order a lens which is 0.25 lesser, so I got a volt of. So remember, for every 100 micron decrease in the size of the phakical, you expect 40 micron decrease in the volt, and you can calculate it accordingly. But for the other sister, 11.4 was the white to white which was measured, and we went for a higher size 1.35 millimeter difference, and we landed it with very high volt which I had to replace. So I went for a 0.5 millimeter smaller phakical, and as the rule, 200 to 300 micron volt was reduced. So always avoid phakical larger than 1.2 millimeter. Otherwise, you have to think a lot whether you want to go for that or not. Now there is an advantage with IPCL because the difference in sizes is just 0.25 millimeter. So you have a lot of things you can vary. Another thing which you can study further is that what I have seen is that most of the high myopes, though we have this general conception that after 18 generally the axial length stops increasing and the myopia stops progressing. But if you look at the patients who have got 26.5 or higher axial length, it continues to increase till the age of 27, 28 as well. And that may be one of the causes that post-phakical in high myopia patient may land up with myopia after 2-3 years. So what I generally do in patients who have very high axial length, I use this algorithm where less than 23 I overcorrect by 1.5, 23 to by 1, and then by 0.5. So this is my personal nomogram which I use. You can try it and it will be useful. Thank you so much, Pooja.
Thank you, sir. It was a very widely covered talk. For the interest of time, we will move on to the last talk for the session, which is on premium IOLs post-refractive surgery, when, why, and how. Yeah, just 5 more minutes. It's okay. Yes, no problem. I'll do that. Thank you.
I'll finish, don't worry. So, I think everyone who has undergone LASIK surgery will want to have this because it's they are doing premium. Okay. So if that is there, then it's going on. So people who undergone and spend so much money for LASIK, an example, will want to do this. So how in the OT? I think in the OT we should have digital image guided surgery. We have to do flax, and of course the paperwork is very, very important because patients. So in the OT, what is important here to understand is that don't make a mistake in seeing the paperwork. So that's important. As far as the OT is concerned, I think look at image guided surgery. You can see that I have done marking with ink, and I've got Virion, which is digital imaging. So this proves that yes, both are equally accurate and this can go on quite well. So really nothing much to worry, but this can happen. So I think image guided procedures like Callisto or Virion, no financial interest anywhere, will give better results as far as it's concerned. As far as flax is concerned, in the operation theater, you can see that I'm making an incision with the help of a keratome, but the image guided procedure is helping me to make sure that the incision is very accurately placed. So I know my SIA, I know exactly how to place the incision, so that is helping me. Then coming to the next part of it is look at the CCC. It's very well centered on the visual axis. Here, so big advantage here is that goes around, and this causes a completely free floating CCC, which you can see here, and this will center the IOL extremely well. So this is one additional benefit that we get as far as the whole procedure is concerned. Then coming to calculations. So post-refractive calculations are very important. I'm now using Anterion. It combines corneal analysis. It does anti-chamber depth, lens thickness, and actual length measurement. Gives the density of the nucleus at the same time. So you come to know. Another most important step is that the spike that is coming from the retina is also well evaluated, and acquisition quality is also summarized. So you get multiple green ticks, which also help. Here you get information from the anterior surface, posterior surface, pachymetry, total cornea, and the refractive index. So the total cornea is the most important information that we are getting. Total corneal power especially is necessary for formulas like Barrett. And of course, the total corneal power for toric IOL calculation is also very, very important. So as far as the information that we are getting from the Anterion is actual length measurement, keratometry, steep cornea, total cornea, total corneal wavefront. So if you have an aberrometry which shows that high order aberrations are much higher, then you may want to avoid using a multifocal IOL, etc. So that again information you get in one shot. Depth of the anterior chamber, white to white and pupil center and angle kappa. So all this information you're getting, all this information is necessary in post-refractive cases. Any error somewhere is going to make a patient unhappy. Here again, IOL calculations, big advantage that you have both the eyes together. So if you have a big disparity between two eyes, it will really happen and you will see a difference between the two eyes. So you can see IOL calculation compared in a single view. One thing, corneal data, anterior axial measurement, angle kappa, all of this data is measured and shown in one case. I'm just showing one case. 55-year-old post-myopic LASIK nuclear sclerosis grade. I wanted to plan a multifocal IOL. Here you can see that it's a long eye. ACD is information that you're getting, lens thickness you're getting, that will tell you your expected lens position. And of course, keratometry and white to white. So all this will happen at the same time. Now IOL calculations that are there, which is there, you can see the IOL calculations. The calculation comes from all different formats. I use all the different formulas that are necessary and I'll tell you a difference. So I use Barrett True K. Of course, we also use Hill RBF and get the information. So here we are getting information from the ACRS calculation, ACRS anterior calculation and IOL master. And you can see that all the IOLs that we are really using is around the same. And I went ahead and did this calculation to get 22 diopter IOL. And you can see the post-op result is that the patient underwent an uneventful trifocal implantation with a 22 diopter in the right eye. And on the 5th day, the patient was 6x6 part N6. Autoref, of course, has no value. So here is one more case that I'm showing that you can see a beautiful round femtorexis. So post-refractive patients are very, very demanding patients because they've had spectacle-free vision for a number of years. So multiple things will help you to get sure that your results are very, very good. Here you can see a nice round femtorexis, which is right well centered. And once the lens is in the bag, big benefit I see is that the lens automatically centers in the bag. You don't have to really worry about it at all. And then another important thing is remove the viscoelastic from in front of the IOL. And also remember to remove the viscoelastic from behind the IOLs. That's another big benefit that you can see here, that it's gone and the viscoelastic is completely removed. Now here, one more thing I want to show you is that I'm not using eric keratome. Now I make incisions, my side port, everything with the help of flax. And you can see the important thing, only I'll take 1 minute more, that this is the incision at 160. Half the incision is on this side of 160 and half the incision is on the other side of 160. So we can get that kind of accuracy with flax. And it's a biplanar incision, so it's extremely self-sealing. You will also notice that I've made the main incision, put in the viscoelastic, and I've also made the side port with the help of the laser. So I'm really not using any MVR blade. You can see that I'm just using an instrument like a Sinskey hook, and that itself opens up the incision. So these incisions are extremely self-sealing. You don't have to worry about leak at all. Go ahead and do your phacoemulsification. Once the phacoemulsification is done, do the bimanual IA. Once the bimanual IA is done, we go ahead and implant the lens in the bag. And these patients do extremely well. So I feel toricity marking, which comes from any of the devices, either you have image guided, all of this will make sure that your results are very, very good till the end of the procedure. So here you can see that the lens placement is at 173. Now this is only possible when you do it at 173. Otherwise, manual marking will cause some errors. Otherwise, you'll have no issue. Thank you for your attention.
Thank you, sir, for the wonderful talk. As we are moving late, I would like to thank all my co-instructors, Dr. Saurabh, Dr. Kumar, Dr. Sir, Dr. Sonu Goyal, Rohit Chetty sir and Saili for coming. And I would also like to thank Lajja ma'am for giving me her 5 minutes from the course. Thank you. And thank you all delegates for coming.